Good afternoon. My name is Allison Kempe. I'm a pediatrician and a health services researcher, and I'm going to present an example of a pragmatic cluster randomized trial. And this first slide just shows my study team. So I don't think I have to convince anybody in this audience of the importance of immunizations, which have been touted as second only to clean water as public health interventions that have decreased death and disease. This slide shows visually the vaccine preventable disease incidences pre and post vaccines for children. So how are we doing? We're at about 70%, and Healthy People 2020 goals are 80% for 19 to 35-month-olds, so we have a ways to go. What are the problems? There are lots of problems to optimal immunization delivery, and that's not the subject of this conversation, so I'm not going to go into them, but there are many. But there are also some evidence-based solutions. One solution that I've studied quite a bit is reminder recall. So reminder recall is the use of postcards, letters, phone calls, texts, emails to inform patients they are either due or overdue for immunizations. Reminder recall can be automated using an immunization information system, or what's commonly called an immunization registry, which exists in all but one state at the present time. Reminder recall conducted by practices has been shown to be effective in increasing rates, but very few physicians nationally conduct reminder recall. So we reasoned that population-based reminder recall conducted centrally by public health departments could offer the advantages of reducing the burden of practices to do this and reaching children that didn't have a usual source of primary care. So we conducted a pragmatic comparative effectiveness trial comparing two approaches to reminder recall. Our objectives were to compare the effectiveness and cost effectiveness of conducting reminder recall using two methodologies, either population-based or practice-based reminder recall, and I'll explain those more in just a second. And we had a number of issues in terms of planning the study design, and Miriam Dickinson will go through these in a little bit more depth. But just to set the stage, we needed randomization to be at the level of the county in order to compare interventions that were occurring at the level of multiple practice units and compared a centralized approach that could occur at the county population level. Outcomes, however, were at the level of the patient, with clustering within practices and within counties. We needed to have the best approximation of the total denominator of children at the county level in order to do this. And we wanted to assure balanced randomization because we didn't have unlimited numbers of counties. In fact, we had pretty limited numbers. Those were some of our dilemmas. So I'll briefly tell you how we solved that, and Miriam Dickinson will then go into more depth about the rationale and exactly how that was done. First, we stratified counties into rural or urban status, and then within these two strata, we performed covariate constrained randomization in order to achieve optimal balance between the study arms with respect to baseline variables of the counties, which we had. And these are the 6 variables we had: percent minority race and ethnicity, median income, percent of 19 to 35-month-olds with greater than 2 immunizations in the IIS, total number of children in those counties, and the percentage and numbers of the types of providers providing care to those children. So here's a visual representation of the randomization. As you can see, we started out with 14 counties, 6 urban and 8 rural. And then within these strata, we randomized in a balanced, covariate constrained manner. In terms of denominating the study population, we used as the denominator for each county the children 19 to 35 months that were in the Colorado Immunization Information System. And it's important to know that this is populated directly from birth vital statistics in Colorado. We then downloaded names and addresses of children 19 to 35-month-olds that appeared to need 1 or more immunizations within all 14 counties. In the population-based recall counties, centralized reminder recall was conducted by the state public health department. using up to 3 mailings to children 19 to 35 months needing immunizations. And the notices suggested patients would go to their primary care provider, or if they did not have one, to the public health immunization site. In the practice-based recall counties, all practices in those counties were invited to attend a web-based reminder recall training, so they didn't have to leave, they could do it on web. And we suggested there the same methodology that was being used in the population-based counties. In addition, we offered financial support for mailings to practices who did reminder recall or actually for phone call time. We also performed a cost assessment in the population-based reminder recall counties. This included estimates of staff time for training and implementation, updating bad mailing addresses, and mailing and printing costs for up to 3 mailings. And in the practice-based reminder recall counties, this differed based on what the practices decided to do. That also included estimates of staff time among practices who conducted reminder recall and their estimates of mailing costs or costs of phone calls, depending on what they did. So this is one of the biggest take-home messages of this pragmatic trial. Looking at the reach of the intervention, which is shown in yellow, we see that in the population-based reminder recall, which had within those counties 188 practice sites, we estimated that we reached 85% of the population because 15% either had returned addresses or we could not correct the addresses that we had. In comparison, there were 195 practice sites in the practice-based reminder recall counties. Only 10 did reminder recall. So the maximum that we could have reached with this intervention was 5%. These are the major outcomes, the percent receiving any vaccine within 6 months of those needing vaccines. And here you see in the population-based counties, 32% received any vaccine versus 23% in the practice-based, with an absolute effect difference of 9%, which from a public health perspective is enormous. The percent brought up to date within 6 months is shown here, 19% in the population-based reminder recall counties versus 13% in the practice-based, with an absolute effect difference of 6%. These are the multivariable models that we conducted for being up to date or receiving any vaccine, pretty close to one another, 1.24 adjusted odds ratio for up to date and 1.27 for receipt of any vaccine. And comparing costs differed notably. These are the costs per practice, roughly $215 in the population-based counties, and $1,300 in the practice-based. Per child who received 1 or more vaccine, $10 in the population-based counties versus $38 in the practice-based. And these are the costs per child brought up to date, $17 in the population-based reminder recall counties and $62 in the practice-based. So there are important limitations to these data. The population is impossible to accurately denominate in all counties, but we use the same method of approximation in both intervention arms. Obviously, children can move in or out of the county, and the IIS would not necessarily reflect that, but that problem was distributed across the arms of the study. The population-based reminder recall was hampered by many inaccurate addresses from vital statistics. So in fact, our results might have been more notable if those data were more accurate. Practices may have conducted reminder recall after the 6-month period of follow-up, but we incentivized them to do so within 6 months, so I'm not sure how much of a problem that was. And costs are approximations because they're based on personnel report rather than direct observation. So in conclusion, at the county level overall, population-based reminder recall was more effective than practice-based because of the lack of participation of practices, even when incentives were provided. Costs per practice or per child vaccinated were much lower for population-based reminder recall. This was funded by an NIH Challenge Grant. And now we're going to delve further into the methods. Miriam Dickinson is going to explain a lot more of the rationale that went into our decisions. Thank you so much.